All right, so for today's call, I want to discuss a question that I get commonly in the practice, and I got it this morning from a patient in regards to chronic migraine. So I'll talk about it in regards to chronic migraine in that patient's case and lab results, just so we have some context to go by, but realize this can apply to any patient, any case where you have tried, the almighty treatment X, whatever treatment X is, and it hasn't worked for you. So I want to help you understand why that may be the case. So let's talk about that in the case of chronic migraine today, and go from there. So if we use a metaphor of you being a bucket, I think it'll help us understand. So I was talking to this patient about their chronic migraine and the fact that they've tried eliminating gluten and they've tried magnesium and they've tried, different things that you can Google or different things that other people with migraines have told you have worked for them, and they didn't work. And so the reason it might not work is what we're going to discuss today. So if you're a bucket and the fluid level in the bucket is your level of inflammation, this concept will help you understand, I think. So our bucket is black. The black level of inflammation is baseline. Okay, so all this in here, let's see if I can, I think I have a fill. But if we filled the below this line with black, that would be physiologic inflammation. So one thing to understand is that, in the media, inflammation gets portrayed as always negative, but it's important to understand that there's a physiologic level of inflammation or a normal level of inflammation. If we had no inflammation, we'd die pretty quickly, because inflammation, the physiologic level of inflammation, is our immune system's way of interacting with the environment and understanding what's going on. Okay, so we should always have some low-level physiologic inflammation, because that is healthy. Okay, that's optimal. But then when we pile on it more inflammation on top of that, that's when it begins to become a problem. So the black level is normal. Please mute yourself if you're not. Now so this patient obviously has the black level of inflammation because they're walking around alive. If we layer the next level of inflammation, in testing this patient, we saw that they have gluten sensitivity. Okay, so we pour some more fluid in the bucket there because of gluten. So that's going to contribute some level of inflammation to that patient. Then, in looking at that patient, we saw that they have suboptimal levels of magnesium. And magnesium is important in migraine because migraine oftentimes has an excitotoxic component to it. And excitotoxicity, I've made videos on this before, I can link to it here. But excitotoxicity is essentially too much calcium getting into the neurons and the neurons exploding, if you want to have a visual. And so the way that the calcium enters the neuron is through this receptor called an NMDA receptor, and you can plug that receptor with magnesium, specifically magnesium glycinate. And so, magnesium can be useful in migraine and in headache for patients who have, especially patients who have the excitotoxic contribution to their migraine. It can also be useful in migraine or in headache because magnesium is one of the best natural muscle relaxers, and headache, especially migraine, oftentimes has a vascular component, an imbalance between vasoconstriction and vasodilation. So the magnesium helps promote optimal smooth muscle tone in the vasculature. Now, we also looked at other nutrients that are important, and this patient had low levels of CoQ10. So if we do that there, CoQ10 has been shown in the research to help mitigate pain in migraine headaches. CoQ10 goes in the mitochondria and promotes optimal ATP production or optimal energy production. If you don't produce optimal amounts of energy, it's hard to heal from anything. Well, the brain is a very energy expensive organ. And so, you know, if it's got high demand for energy and your ability to pump out that energy is poor or suboptimal, maybe this patient manifests with migraine, maybe I would manifest with anxiety and you would manifest with vertigo. Who knows? Okay. Next level, this patient had low iron. The brain needs fuel, and its two favorite fuels are oxygen and glucose. Okay. Oxygen is carried to the brain via iron. And so if we have low iron, you may not oxygenate the brain well. And again, if the extreme case would be if you cut off oxygen to the brain, you pass out and or die, right? But say you have a less than extreme case, suboptimal oxygenation may lead to suboptimal functioning. And again, if your weak link is a migraine headache, that's more migraines for you. If my weak link is anxiety, maybe it's more anxiety for me. So we want to oxygenate well. Glucose is also important. This patient had optimal blood sugar regulation, so that was not an issue in this person. Vitamin B6 was low, and vitamin B6 is another key brain nutrient. Like the magnesium, it is key in preventing the excitotoxic process. It's also key in producing our anti-anxiety neurotransmitter GABA. If you don't have enough B6, you can't make GABA from glutamate. And if you have a backup of glutamate or a buildup of glutamate because of that, glutamate is the excitatory neurotransmitter that can drive that excitotoxic process forward and result in a migraine. So B6 levels can be very important. Omega-3 levels. This patient had low omega-3s, especially EPA, which is the natural NSAID, so to speak. It's the most anti-inflammatory of our fish oils. And then she also had low DPA levels, and DPA is a more vascular functioning omega-3. Remember, migraines oftentimes can have, you know, vascular issues with constriction and vasodilation in them. Let's get another color. Do we have any more? Let's go light blue. All right. So light blue here, TGF-beta. Okay, her TGF-beta level was lab high, over 10,000. Okay, and TGF-beta, there's research, if I'm remembering the paper properly, it's the Journal of Pediatric Neurology. There's a paper published in that journal that's where the researchers looked at pediatric migraine and transforming growth factor beta gene variants. And the paper found that people with genetic SNPs or genetic variants in the TGF-beta genes have increased risk of migraine with or without aura. Well, in conventional medicine, TGF-beta is almost never run by your doctor. So if you're a migraine patient and you're not getting better with the, you know, standard Google treatments, well, then perhaps you should have your TGF-beta run, because you may have genetic variation that's promoting higher levels than normal there, and that can drive migraine in some people. And then another marker here, let's use this one, is, oh yeah, that's good, is lipoprotein A. So lipoprotein A is what it says. It's a lipoprotein, so it's similar to, you know, it's in the cholesterol family. One second here, I'm having troubles writing. Okay, so lipoprotein A is in the cholesterol family, and it's actually an independent risk factor for cardiovascular disease. And so you might say, well, why is that related here? Well, in a different research article, neurologic journal. I looked for, is there any connection between lipoprotein A and migraine? And again, this journal found, they looked at pediatric migraine and they found a correlation between high LPA levels and increased risk of migraine. And specifically, when you look at your labs, it will list LPA. It'll list LPA, your LPA results, and that result will be listed in milligrams per deciliter. And the paper used 30 milligrams per deciliter as the cutoff between, say, too high or not too high. Okay, so less than 30 is good, greater than 30 may be contributing to migraine. This patient I was speaking with this morning's level was 113. So it looks like this may be contributing to her migraine via the mechanisms laid out in that paper. So we want to decrease the LPA level and see, does the migraine level improve? And so this is enough of the case. There's more going on in the case, but this is enough to fill our bucket for this video. So remember that the black is physiologic level of inflammation. All the other colors are piled on due to nutrient insufficiencies or inflammation or lack of anti-inflammatories or diet, and maybe malabsorption of the diet or things going on in the gut. And so if you have, like in this case, chronic migraine, and you've tried the best Google treatments or the most commonly effective ones, like, hey, I cut out gluten and I took magnesium, right? Well, and it still didn't help you, well, then probably your bucket has more colors in it or a higher fluid level than that deals with. So for example, if we just erase the LPA, okay, then that only lowers our bucket level that much, right? And so that might, that might not be perceptible in your case. That might not be enough for you to notice a decrease in symptoms. But if we lower the LPA and we lower the tgf-beta, well, now maybe that's enough for you to notice improvement in symptoms. Or if we get your omega levels up, that again lowers the level. So you see what I'm doing here is we need to understand all the things that are pouring into the bucket so we know clinical targets to pursue to empty the bucket as much as possible. And eventually, if we successfully address enough of those inputs and eliminate them or get rid of them, then we pour out enough fluid in the bucket for it to result in a clinically meaningful symptomatic relief, hopefully even healing. So ideally, you get back down to just the physiologic level of inflammation, but matter has limitations, and sometimes people have, say like in TGF-beta, they have genetic variants that might make that a longer term issue to deal with. But if that's the only fluid in the bucket, in addition to the physiologic level, the likelihood is this person has very infrequent and maybe even rare or maybe never again has migraines. So if you're someone that's got an issue that treatment X that's helped everyone else hasn't been the key for you, then your case likely is more complex than the person who was helped by treatment X only. So work with somebody who can do the detective work to help understand your bucket and all the inputs going into it so that you can achieve a life at optimum.
So people who get migraines from MSG, monosodium glutamate, they could possibly have a B6 deficiency because the B6 is not being able to process that glutamate.
Potentially.
Or is that?
Yeah, that would be a, yeah, that could be one way. So if we use just G, what color do I have? Brown. If we just use G for glutamate, or let's do GL, glutamate becomes GABA. And GABA is the natural anti-anxiety neurotransmitter, okay? But there's an enzyme for that conversion to happen. That enzyme is called GAD65. And an enzyme is a protein that does work. All enzymes require nutrients to function. There's nutrient cofactors that allow that protein to do its job. So in this case, GAD65 requires magnesium, requires iron, and it requires B6. With B6, for this enzyme is the rate limiting step, meaning it's the most important one. If you don't have B6, this won't go forward even if you have the magnesium and the iron. So you get blocked here in the buildup of glutamate. So if the person's B6 deficient, then their glutamate's built up already, and then they add MSG to that, and they're piling on faster, right? So yeah, that would not be advantageous if the goal is symptomatic improvement. And you might notice in this person, they had all three, right? There's magnesium, there's B6, and we already and iron here. So, you know, this is probably one mechanism contributing to the migraines in that person through an excitotoxic process. And interestingly, a very common driver of excitotoxicity in migraine is homocysteine and, you know, poor methylation. And this person has an MTHFR heterozygous SNP, so one good copy, one bad copy, but her homocysteine was beautiful at 6. So again, that's why we don't treat the paper when we're looking at genetics. It's just another piece of information to look at in the context of the case. But many doctors would just run the genetic test and see the MTHFR SNP and be like, oh, you need tons of methylfolate because your homocysteine is probably high. And it's like, well, no, you can actually test homocysteine and folate and see that both of those are fine in this person. So, you know, that's a potential that's not being expressed in her case.